a biphasic appearance, that means it comes and goes and then comes back again. The history is that of Ebsteins anomaly. And cyanosis, which occurs later in childhood or in adolescence, could either be Eisenmenger syndrome. It could be a pink tetralogy, which has gone into now cyanosis. It could be a ventricular septal defect developing pulmonic stenosis, the so-called Gazul's phenomena, and then triology of Fallot. So these are history-wise, you can sort of separate them out. If there's a history of squatting and spells, it is the first diagnosis of tetralogy. It could uncommonly also be Eisenmenger. If you have hemoptysis, then if it is later on, it is Eisenmenger. Early on, it is tetralogy. So both can present with hemoptysis. Recurrent respiratory tract infections in infancy, the history would point towards Eisenmenger. Now, what is heart failure? Frequent lower respiratory tract infections, interrupted feeding, dyspnea, failure to thrive. All these are features of heart failure, and expect some kind of admixture lesion where you have increased pulmonary blood flow. If your presentation is heart failure and acute pulmonary edema, probably you could be having hypoplastic left heart syndrome or a total anomalous pulmonary venous connection, which is obstructive. And heart failure in the adolescent, basically think of triology. So history-wise, these are the pointers. Then the history is that of maternal history, and some of the important points is that if you have diabetes, then possibly you could be having transposition, we really don't know. History of alcohol, transpositions, history of sex hormones, tetralogy and hormones. Lithium, of course, is very specific for Ebsteins anomaly. Trimethadone history, tetralogy, transposition, HLHS. Estrogen, once again, the sex hormones, TOF and TGA. And sometimes when you say that the child was, later on in birth order, you could also think of a TGA. Now, the history-wise, what are the symptoms of heart failure? You will be feeding difficulty where the infant is sucking less than 3.5 ounces per feed, just about 15 to 20 minutes, cannot complete it in that time frame, feeds every hour, 2 hours, is tachypneic, and he has that suck, rest, suck cycle going on, and there is a failure to thrive. And failure to thrive is when you have less than the third percentile of the weight expected for that age. Basically, infants and newborns will present as tachypnea, and the older ones will present with dyspnea. And tachypnea is when you have more than 60 per minute in newborns and more than 50 in the infants. There will be intercostal retractions, subcostal retractions, and there will be grunting and nasal flaring. History of fatigue simply means that the infant is not able to feed, and then when it is an older child or an adolescent or adult, then you have to question on the specific age activity which is specific for age. This I've already said, failure to thrive means that the weight is less than the third percentile for age, and the weight gain is often more delayed versus the height. And this is because the child is not taking enough and spending more because of the increased respiratory effort in heart failure. So there is a weight gain which is not occurring in a proper manner. Now, the question often asked in the examination, what is repeated lower respiratory tract infections? And this is indicative of increased pulmonary blood flow. So the definition is that if you have 2 episodes of pneumonia in a year or 3 episodes in any time frame, that's the definition. And the question often asked is, why do you get repeated lower respiratory tract infections in pulmonary blood flow? The answers are many, but basically it is because the pulmonary arteries were engorged, they compress the bronchi, cause microatelectasis. There is hyperplasia of the goblet cells, which are producing more mucus, and there is a defect in the mucociliary function. This is often not answered by the candidate. So you're producing more, they're causing stasis because of compression, and you're not able to clear it because of the defect in the mucociliary function. Blood pooling, of course, leads to a nidus for more infections, bacterial growth, stiff lungs do not, you're not able to throw out enough secretion. So all this leads to repeated altriae, and the definition is 2 episodes of pneumonia in a year or more than 3 episodes in any time frame. Chest pain is rare in infants, but if they occur, then probably dealing with the left ventricular outflow tract obstruction, right ventricular outflow obstruction. and some coronary anomalies, coronary fistulae. Ruptured sinus of Valsalva is also an important cause of chest pain in a cyanotic heart disease. Syncope always indicates some kind of LV outflow obstruction or an RV outflow obstruction, whether it is the pulmonary valve or beyond the pulmonary valve into the vasculature. And then, of course, never miss out on the channel apaces, the long QT and the short QT syndromes. Whenever we talk of edema in children or in infants, the usual site of edema will not be on the feet, but it will be more in the periorbital region or the pretibial or the presacral region. So all these things you must remember, because these are the questions that are sequentially asked when you narrate the history. You should always know about the velocardiofacial syndromes and why they occur and what are the features of the DiGeorge syndrome. And this is the type of phases that you have. You should all know that. There's no point in going them into one by one, but basically you should know what are the features of the DiGeorge syndrome, because that is associated with tetralogy of Fallot. Then the fetal alcohol syndrome you should know about trisomy 13, what it means, and then be very, very careful with Down syndrome. So this is a very classical, facial expression of the Down syndrome, and one often talks about this single palmar flexion crease. And these are the questions that the examiner may ask you as to what are the features of Down syndrome. And Down syndrome basically presents to you with, the acyanotics, the endocardial cushion defect, VSD secondum PDA. But tetralogy of Fallot is also associated, and 50% of patients with Down syndrome will have some kind of heart disease. So be now prepared with, these syndromes also. So now let's get on to physical signs that may be helpful. If you have bradycardia, then you could be dealing with an LTGA or navy canal defect. If you have a high volume pulse, then tetralogy with aortic regurgitation, truncal regurg. So basically, these are all things that you must have in your mind and be able to produce to the examiner. If you describe a high volume pulse, what are the possibilities? So this you should know: radiofemoral delay and coarctation, and patients with tricuspid atresia. If you have a reverse kind of cyanosis, then you could be dealing with a transposition situation or a Taussig-Bing anomaly, double outlet. Always remember that if there is tetralogy of Fallot, then you cannot have coarctation with tetralogy. Why? Because coarctation can only occur if there is reduced flow into the aorta. And in tetralogy, you always have increased blood going into the aorta, and therefore you cannot have coarctation, because unless you have reduced flow, you will not get coarct. So TOF and coarctation do not coexist. If you look at the precordium, now you have to basically say as to which side the apex is lying, on which side you have dullness of the liver, on which side you have dullness of you have a tympanic node of the stomach. So that you should know. And these are things that one should always remember. This is a mirror image dextrocardia, where all the cytoses are reversed. The stomach bubble has also come to the right side, the liver has gone to the left, and the apex is also right side. So basically, you do not get any abnormalities here. Abnormalities will be found where you have isolated levocardia, where the situs is reversed and says that you have the abdominal situs is reversed, the stomach has come here, the liver has gone here, but the apex remains on this side. And so this is isolated and is always associated with complex congenital heart disease and quite commonly associated with L transpositions of great artery. Mesocardia simply means that the middle part of your heart is in the mid, that is the longitudinal axis of the heart lies in the mid sagittal plane. And the incidence is quite low and mostly occurs with situs solutus, and corrected transposition is once again a possibility in this. So this is a case of mesocardia, and you have the left-sided aorta here. So once again, corrected transpositions, complete transpositions are common, but as such, mesocardia is not a very common situation. Isolated dextrocardia, once again, the same example. You have the isolated dextrocardia over here. That means that you have an apex which is right-sided, but the stomach bubble and the liver are in the normal. So this is isolated dextrocardia. This also is associated with complex. So whether it is isolated levocardia or whether it is isolated dextrocardia, Both these situations will have. So in your physical examination, always talk about the liver dullness, the tympani of the stomach, and the apex, whether it is right or left side. Now in tetralogy physiology, now you have to go to see whether you have a left ventricle or a right ventricle. So in tetralogy physiology, the vast majority would be right ventricle. And if you have a left ventricle, then these are the situations where you can have left ventricle. The most important being tricuspid atresia, single ventricle of the double inlet type, double outed right ventricle, where you have sometimes a diminutive or a restrictive ventricular septal defect where the LV becomes dominant. Then pulmonary atresia with intact septum, once again, lots of blood flowing into the left side. Ebsteins anomaly sometimes can have a left ventricular dominance, and tetralogy with a lot of collaterals filling the left ventricle can also give rise to an LV. Large BT shunt created on surgery. So these are some of the causes where in tetralogy physiology you can get a left ventricle. It's a very common question that is asked in the examination. If there is increased pulmonary blood flow without any pulmonic stenosis, then you will have an RV plus an LV. So mostly in tetralogy physiology, you will have an RV. Sometimes you can get an LV, and these are the situations. And if you have an increased pulmonary blood flow, such as simple ventricular septal defect, or a transposition physiology which behaves like a ventricular septal defect, or a double outlet right ventricle which behaves like a simple VSD, you can have a biventricular LV and RV both. And if you have just a drainage of LSV into LA, or unroofing of the coronary sinus, or pulmonary AV fistulae, then you can have neither LV nor RV enlargement. Normal situation would be there. Now, this is something which is often asked. If you have dullness in the left intercostal spaces, what can it be? It could either be a pulmonary artery, where you have tetralogy, Eisenmenger, or it could be an aorta, which is L transposed. This means that the aorta and L transposition could be pulsatile, but mostly it will be just dullness of percussion in the second left intercostal space. If you have an increased pulmonary blood flow with Eisenmenger, still the shunt is left to right, you can have a pulsating pulmonary artery. In pulmonary artery with stenosis, you might not get any pulsation, but you will get. So this is regarding dullness as well as some prominent pulsation in the second intercostal space. Could be a PA with triology and Eisenmenger, or it could be the aorta and L transposition. If you have a dullness slightly lower down on the left side instead of second intercostal, so the right intercostal, the third left intercostal, it could be an inverted outlet chamber in a single ventricle situation. So sometimes you have to remember these things, and reproduce them whenever the question is asked. What about sounds? S1 is generally normal, but it could be split in Ebsteins. S2 is single in tetralogy. In tetralogy physiology, if you have a loud A2, you could be dealing with a tetralogy, L transposition, truncus, and a loud P2 means pulmonary arterial hypertension. But the question sometimes asked is, if the S2 is single, how do you know this is a loud A2 or a loud P2? Now, a single second sound in tetralogy physiology will be A2, and in tetralogy and in Eisenmenger physiology, it will be P2. So basically, you have to correlate it with the clinical findings. But if a question is asked, then the answer could be that if I can hear the second heart sound best in the second intercostal space, it is likely to be a P2. And if I can hear it best at the apex, it is likely to be A2. Hearing second heart sound at the apex does not mean that it is loud A2. It has to be best heard in the apex to say it is a loud A2 on a single second heart sound. So often, these little things are asked, and the candidates get confused. So S2 single means a loud single means it could be a loud A2 or a loud P2, and try to correlate it with the situation you're dealing with. If you're dealing with tetralogy and transposition, it could be A2. If you're dealing with PH, you're dealing with a loud P2. A split S2, once again, TAPVC and RV failure. And if you have gallops, that means that you have increased pulmonary blood flow in association with less cyanosis. You have increased pulmonary blood flow across the mitral valve into the LV, causing a third heart sound. Aortic and ejection sounds are heard in tetralogy physiology. And some of the books write that despite the fact that we have known that variation, that inspiratory decrease and an expiratory better heard of ejection sound with a pulmonary situation is only when the ejection sound is valvular in origin. It does not vary with respiration if it is vascular in origin, that is because of pH. Similarly, the ejection sound of the aortic side does not vary with respiration. But in some of the books, it is said that in tetralogy of Fallot, because the aorta is connected to the right ventricle, despite the fact that the septum is deficient, you may have some respiratory variation. In that, it is better heard in expiration than in inspiration. So, by and large, the answer should be that the aortic ejection sound does not vary with the respiration. Only the valvular ejection sound of the pulmonary varies with the respiration, not the vascular. But sometimes even aortic ejection sounds in tetralogy can vary with respiration. S2 in top physiology is usually single. It is palpable in transposition of great arteries, even in tetralogy, because the aorta is now situated anteriorly. So you can have S2 because of a loud A2 being heard on a left side, which is, and even palpable because the aorta is now anterior. An impure S2 means truncus. A loud P2, this is also some questions that is often asked, that in tetralogy of Fallot, you have a loud P2 because you expect a soft P2 here. But if you have a loud P2 in tetralogy, you could be dealing with an associated peripheral pulmonic stenosis. Murmurs, the ejection systolic murmurs, if you hear it in the third left intercostal space, it is because of pulmonary stenosis in tetralogy of Fallot, and this is known to everybody that the more the cyanosis, the more is the severity of the pulmonary stenosis, and the lesser will be the intensity and the length of this ejection murmurs. In fact, if the patient is deeply cyanosed, then you might not hear a murmur at all. Now, if you have a murmur slightly higher up, instead of the third intercostal space, you have an ejection murmur which is slightly higher up. It could be double outlet right ventricle. And if you hear it slightly on the right side, it could be because of transposition of great arteries. So the situation of ejection murmur is also of importance, and you should remember that. The second sound is the key to auscultation, and the best example of its utility is in ventricular septal defects. Now, if you have a large shunt, large VSD with shunt, no pulmonary arterial hypertension, the second sound is widely split, normal, variation, and P2 is also normal. If you have a big shunt and you have pulmonary arterial hypertension, hyperdynamic pulmonary arterial hypertension, you have a wide, still variable splitting of the second heart sound, but now the P2 will become loud. Now, if the pH is so much that the shunt is becoming smaller and the patient is going towards Eisenmenger, that split, instead of being wide, now becomes narrow. So you have a narrow split of the second heart sound, loud P2, and this is what is often presented in the examination. Any case of pulmonary arterial hypertension always presented as a narrow splitting of the second heart sound with a loud P2. Narrow splitting means that you have an A2 P2 distance of 30 seconds or even less, but you can hear the split in inspiration because P2 is loud. Now, if you have an Eisenmenger situation, then the second heart sound will become single because A2 is now over P2. If the left to right shunt is there with the PS, once again the splitting will be wide and the P2 here, instead of being loud, will become soft. If you're going towards tetralogy physiology, P2 will be so soft that S2 will become single. And of course, if the VSD is small, then you will have a normal S2. So S2 is the key to auscultation. Now, if you have pansystolic murmurs, then they could either be because of ventricular septal defect or MR or TR. Now, sometimes we often tend to ask you what is an obligatory VSD and what is an obligatory shunt. An obligatory VSD is where the blood flow has to occur across the ventricular septal defect, and that is associated with tricuspid atresia and double outlet right ventricle. Murmur is heard when you have a restrictive ventricular septal defect. Murmur will be heard when you have a restricted ventricular septal defect. How do you differentiate between the two? If you have an ECG which is showing RVS, you're dealing with. If you have an ECG which is showing a left ventricular hypertrophy and the RVH is absent, it is TA. And if you have an ECG showing right ventricular hypertrophy, it is double outlet right ventricle. So obligatory VSDs in TA and DORV, the difference would be no RVH in tricuspid and RVH in DORV. Obligatory shunts are where the shunt will occur from left to right, whatever the pulmonary vascular resistance, and those are the two situations where you have a Garbodi shunt from LA to RA. The shunt will occur, and in rupture sinuses of Valsalva, where the shunt will occur from left to right. It is not dependent upon pulmonary vascular resistance. So this is obligatory VSD and obligatory shunts. Now from VSDs to murmurs of regurgitation, tricuspid regurgitation, if you have endocardial cushion defect, if you have either severe PS or PH, Eisenmenger, wherever you have tetralogy or pulmonary arterial hypertension or severe PS, where you have tricuspid regurgitation, you will have a murmur of TR. What about a murmur of MR, where you have endocardial cushion defect? And very importantly, often, the patient, the examiner tends to ask, how will you get a pansystolic murmur in Ebsteins anomaly of mitral regurgitation instead of tricuspid regurgitation? It is a left-sided Ebsteins in L transposition of great artery. So remember this, that you will get a murmur of TR with routine Ebsteins, and you will get a murmur of MR where you have a left-sided Ebsteins anomaly in the setting of L transposition of great arteries. Diastolic murmurs, if you have a mid-diastolic murmur, it is increased flow across either the mitral valve or the tricuspid valve. Increased flow across the mitral valve, patients with tricuspid atresia, pulmonary atresia intact septum, left-sided Ebsteins in LTG. Increased flow tricuspid, Ebsteins, AV canal defects, TAPVC. So this is all mathematical. You know where you will have increased flow across mitral valve and where you will have increased flow across the tricuspid valve. In both these situations, you will get diastolic murmurs. Early diastolic murmurs. Now, these are also important wherever you have aortic regurgitation in tetralogy of Fallot, or you have an absent pulmonary valve in tetralogy of Fallot, where you have a truncus with regurgitation, and we have AR murmurs. And you can also have a PR murmur when there is Eisenmenger or PH situation. So these are the causes of early diastolic murmurs. Now, what is important is a lot of situations, cyanotic heart disease can have continuous murmur. The most important being collaterals, and PDA is the biggest collateral. So PDA, other collaterals, peripheral pulmonary arterial fistula, total anomalous pulmonary venous connection, truncus very rarely, and surgical shunt. So all these causes should be known to you. You should know that collateral murmur is soft, it's like a venous herm. It is not very harsh like that of a PDA. The PDA is situated just below the clavicle. Collateral murmurs will be widely distributed over the chest. Total anomalous pulmonary venous connection, uncommonly you will have continuous murmurs. They are heard higher up or suprasternal notch, and they could be because of two reasons: because of the large flow itself, and predominantly also because of any obstruction in the venous channel. So PAPVC uncommonly can give rise to continuous murmurs. Pulmonary arterial fistula, we have already said they are very soft. They do not have any cardiomegaly, and P2 is normal. Truncal continuous murmurs because of obstruction of the origin of P are so rare that it is impossible to make a clinical diagnosis. Now, while it sounds, we should remember that you have typewriter keys and action sounds, multiple heart sounds, split S1, split S2, S3, S4, and Ebsteins anomaly. So now with that physical background, it might be a little difficult for you to go into the 5 TDSs of tetralogy physiology. You made the diagnosis of tetralogy physiology, but how do you go into the 5 TDSs? And there you will have to depend upon the X-ray, ECG, and of course the echo. Dullness, we've already talked about. If you have dullness in the second intercostal space in a tetralogy physiology situation where you do not expect the pulmonary artery, think of that being the aorta and that being a transposition of great vessels of the Levo type. So tetralogy physiology where you don't expect a pulmonary artery in the second intercostal space and you have dullness and percussion, think of L transposition. Now, we've already enumerated the causes of a left ventricle, which is clinically evident in the setting of tetralogy. And remember, DST, double outlet right ventricle, single ventricle, and tricuspid atresia, the 3 common causes of finding an LV in a tetralogy physiology situation. DST, double outlet, single ventricle, and tricuspid atresia. S1 is usually normal. If it is loud, then sometimes people talk of that being a valvular pulmonic stenosis in association with tetralogy subvalvular, and they say that there is an ejection sound which will merge with S1 and make it loud. But we best forget about it. So S1 by and large will be normal in tetralogy physiology. Now, we have also triology physiology where you have severe pulmonic stenosis and an intact ventricular septum. And this is a question which is often asked in the examination, how clinically you can differentiate between tetralogy and triology. You will be cyanosed in both cases. The JVP in triology will be raised while it may not be raised in tetralogy. But later in life, yes, JVP can be raised in tetralogy. But in early childhood, it may not be raised, while it will be raised in triology after the initial couple of years. Left parasternal heave is absent in triology because there is a equalization of pressures on both sides. It is present in triology. S2 is single in tetralogy, it is wide and fixed. P2 is reduced here also, reduced here. If the pulmonic stenosis is there, but the septum is intact and there is no reversal through ASD, then the P2 will remain normal. The P2 can become soft only when there is reduced flow across the pulmonary valve. And that occurs in only two situations, where you have decompression onto the left side, either through the atrial septum or through the ventricular septum. So S2 is soft here. Why? Because there is decompression of the right atrium into the left atrium. You will have S4 and you will have S3 if TR is severe. Pulmonary ejection murmurs will be present in both conditions, but pansystolic murmur is more likely to be present in triology. So these are the clinical findings. Now, you also have an Eisenmenger syndrome. So how do you differentiate the Eisenmenger? There will be cyanosis in both situations. The JVP would be raised. Now, what about RV heave in Eisenmenger? The question often asked is, will you have an RV heave in Eisenmenger? The answer is, in VSD and in PDA, you do not get any RV heave. It is only in ASD Eisenmenger that you will get RV heave. There will be no significant cardiomegaly in ASD, VSD, Eisenmenger, but it will be there in ASD. P2 is loud and you have an early diastolic murmur. So these are the clinical features of Eisenmenger. And sometimes when you have an adolescent given in the examination and you have Eisenmenger VSD, in Eisenmenger VSD, we have said that the S2 can be single and the precardium can be silent because it is not ASD. So when you have a loud single S2 and you have a silent precordium, how do you differentiate it from tetralogy physiology? And there is something which is often difficult for one to differentiate. That often you make the diagnosis of tetralogy physiology and turns out to be Eisenmenger VSD, and you make a diagnosis of Eisenmenger VSD and it turns out to be tetralogy in a situation where you do not have any history of recurrent respiratory tract infections in the early childhood. So what do you do? In tetralogy, the single S2 will be loudest at the apex. Now, this is something which we've already discussed. If you have a single S2 which is loudest at the apex, that means it is A2. So in tetralogy physiology, the loudness of the second heart sound will be because of a loud A2. And if it is a loud A2, it will be better heard at the apex vis-a-vis the pulmonary area. And there will be no ejection systolic murmur. There will be an early diastolic murmur in Eisenmenger. So in Eisenmenger, you would not get an ejection systolic murmur, which you were getting in tetralogy. But ejection murmur can be absent in tetralogy if there is severe cyanosis. So the only feature could be an early diastolic murmur of pulmonary regurgitation. But you can say that early diastolic murmur of aortic regurgitation can also occur in tetralogy. So perhaps Ghum Firke, you only idea about tetralogy and Eisenmenger could be a second heart sound which is better heard the apex. If it is better heard at the apex, it is tetralogy. If it is better heard in the pulmonary area, it is possibly Eisenmenger. But sometimes it becomes very difficult and you will have to depend upon the X-ray. The X-ray immediately will give you the diagnosis. Because if the main pulmonary artery segment is absent, it is tetralogy. If the main segment is full, bloated, prominent, it is pulmonary arterial hypertension or Eisenmenger. How do you differentiate between Eisenmenger and triology? In triology, you will have an RV heave. In Eisenmenger, except for ASD, you will not get an RV heave. But the important point is that here the P2 will be soft, and here in Eisenmenger, P2 will be loud. In Eisenmenger, you have an early diastolic murmur of PR. Here you will not get a murmur of PR, but an ejection systolic murmur. So it is not difficult to differentiate between triology and Eisenmenger when you have an adolescent given to you in the examination. And it is the most simply stated by Dr. Rajan Tandon that the second sound could let you know as to what you are dealing with when you have Eisenmenger. If you're dealing with the ASD, it is a wide fixed split. If you're dealing with VSD, it is a single second heart sound. If it is with PDA, it is a normal split. But I think this is an oversimplification because this you don't get all the time. But yes, if you have a wide fixed split, it could be Eisenmenger ASD, single Eisenmenger VSD, and a normal split in Eisenmenger PDA, but simplified. What about S2 and hyperkinetic that we have already talked in the setting of VSD, so we'll skip that. How do you differentiate between hyperkinetic versus obstructive pH clinically? Hyperkinetic pH you already know is because of increased pulmonary blood flow, but without any increase in pulmonary vascular resistance, you have a hyperkinetic pH. When you have pulmonary vascular resistance rising, then you have obstructive pH. How do you differentiate between the two? In a hyperkinetic pH, the flow will be large. So when the flow is large, what do you expect? You expect cardiomegaly, you expect a hyperkinetic paroxysmal impulse, and you expect a shunt murmur and a flow murmur. Flow murmur at the tricuspid or more commonly at the mitral valve. So cardiomegaly, hyperkinetic impulse, shunt murmur, and a flow murmur across the AV valve. Now, if you have obstructive pH, that means now the flow is going down. Now, once the flow is going down, the patient is going towards Eisenmenger or is already in Eisenmenger, then the heart size will start coming back to normal, except for an ASD situation. The parastern will be heaving in ASD, but it will likely be silent or nearly silent in a case of VSD or a PDA. There will only be a mild heave. It can be slightly more prominent in ASD. Here, there will be a hyperkinetic paroxysmal impulse. Pulmonary vascular clicks will be heard and no flow murmurs, as they were so prominent here in a hyperkinetic situation, will not be present. So it is not difficult to differentiate between a hyperkinetic pH and an obstructive pH, because in both situations, P2 will not help you differentiate. P2 will be loud in both situations, but if you have no flow murmurs, if you do not have any significant heave, and the heart size is normal, you're probably dealing with an obstructive type of pulmonary arterial hypertension. So that was the clinical presentation. Now in 15 minutes, if you have time left, then the next silly question the examiners often asked is, what would you like to see? And often your response in your mind is, neither, sir, just show me the echo and get on with it. But then you have to answer. So let's go on to look at the ECG, because often when the examiner asks you, you tend to say that, sir, I want to look at the X-ray, or it doesn't matter, show me anything. But I think you should go to make a choice on the ECG, because if you are confused between PH and PS, if you're not till your clinical examination made up your mind regarding whether it's PS or PH, only there then X-ray will help you. Otherwise, the X-ray is not going to help you. As you said, if the main pulmonary artery segment is absent, it is PS. Otherwise, it is PH. PS, subvalvular variety. Pulmonary artery could be prominent even with, and before we end, then I'll take up the X-ray on that point also. So let's say let's ask for the ECG instead of asking for the X-ray. Now, the frontal axis is important when you look at the ECG in tetralogy physiology. So the plan is, first you should identify the quadrant. And to identify the quadrant, the two leads that you need to look at is lead 1 and AVF. Often the students are confused as to what we do. So just try to remember what I'm telling you. Look at AVF and lead 1. and identify the quadrant. So if your quadrant is here, look at 1 and ABF, and if both are negative, that means your quadrant is northwest. Northwest, and this is what we will subsequent. So just look at lead 1 and ABF, and if both are negative, then you are in the northwest quadrant. Now, once you have identified the quadrant, the left upper quadrant, by seeing that the lead 1 is positive and ABF is negative, and ABF negative and LBF lead 1 positive means that you are in quadrant. Now, once you are in this quadrant, remember these two leads go together, lead 2 and AVR, and you are looking for an equiphasic complex. So the first step was lead 1 and AVF, and the second is look at equiphasic complexes and where they are lying. Lead 2 and AVR are the ones where you will look for equiphasic causes if you are in this quadrant. And if your equiphasic is in lead AVR, you are in lead 2, sorry, you are in minus 30, and if it's AVR, then you are minus 60. So just remember to look at the equiphasic. Now, if your 1 AVL has shown that your axis lies in this quadrant, you have to look at lead 2 and AVR. If it is lead 2, you are dealing with 150. So if your equiphasic complex is in lead 2, you're dealing with 150. And if your equiphasic complex is on AVR, then you're dealing with 120. Because if it is AVR, then this means that you will have an equiphasic or a small complex in this lead, because the axis is at right angles to AVR. If your axis is at right angles to lead 2, you have an equiphasic complex in lead 2, and the axis is 150. So what revision I'm trying to tell you is that the first step is look for lead 1, AVF, identify the quadrant. If you're both are negative, you are in the northwest. If you have identified the upper quadrant, look for lead AVR in lead 2. What is the equiphasic? And then if it is in this quadrant, look at lead 2 in AVR, and whatever lead shows the equiphasic tells you whether it is 150 or 120. So you can build up your own plan, but this is a plan that I generally follow. Now, if your equiphasic, if your quadrant is in this region, you are more or less dealing with a normal axis, and here you have to look at lead 3 and AVL. There you are looking at lead 2 and AVR. Here in this normal quadrant, you are looking at lead 3 and AVL. And if it is lead 3 which is showing the equiphasic, then your axis is plus 30. And if it's AVL which is showing equiphasic, your axis is plus 60. So just remember or try to build up your own mnemonic, as I said. But the first step is to look for quadrant, and the second step is look for equiphasic complexes. And lead 3 AVL and lead 2 AVR go together. So just ratify this: lead 2 AVR go together, lead 3 AVL go together, and these are used to get the axis by seeing which one of them is showing an equiphasic complex. And if it is in the no man's land, that is, it is in this quadrant, you're not sure whether the axis has gone from the right side or the axis has gone from the left side. And there you could use whether it is a clockwise loop or a counterclockwise loop. Clockwise loop, often as asked in the examination, means that you have a Q wave in 2-3 AVF. So if you have a Q wave in lead 2-3 AVF, you are dealing with a clockwise loop. And if your axis lies in this quadrant and you have a clockwise loop, then it is an extreme right axis which has gone into this northwest zone. On the other hand, if it is a counterclockwise frontal loop, you have a Q in 1 AVL, it is an extreme left axis. That means you have gone into this quadrant from the left side. So if you have an axis in this and you're not sure whether an extreme right or an extreme left, go by the loop, whether it is counterclockwise or clockwise. If it is clockwise, it's extreme right. If it is counterclockwise, it's extreme left. And clockwise means lead 2, 3 AVF showing Q, and counter means Q in 1 AVL. So also this has to be remembered because it's often asked in the examination. Now, axis deviation, once we've determined whether it is a left axis or it is a right axis or a normal axis, now it is going to help you in the diagnosis. If you have a right ventricular hypertrophy and a left axis deviation, most of the times, these are the conditions. Most of the conditions will give you RVH, but if you have RVH with left axis, because RVH normally should give you a right axis deviation. But if you have a RVH with left axis deviation, then you are dealing with an AV canal defect. Double outed and single ventricle, you will fit in everywhere because these are two conditions where you have such a variety of axes and such a variety of combinations of ventricular hypertrophy that you will find it everywhere. But remember, if you have RVH with left axis, you have AV canal defect or even a large inlet ventricular septal defect, which can give rise to this axis deviation RVH. Now, left axis deviation normally will go with left ventricular hypertrophy, but this combination in the setting of cyanosis gives you a diagnosis of tricuspid. So the moment you have LVH and a left axis deviation in a setting of tetralogy physiology, your only diagnosis would be tricuspid atresia. So axis deviation, left axis deviation, LVH, great combination to give you a diagnosis of tricuspid atresia. Now, RVH with right axis, that is the most combination with all tetralogies, but the degree of axis deviation can help you. If the axis is in the region of 90 to 150, anything, even tetralogy physiology can give you this kind of axis. But if your axis is more than 150, then you are probably dealing with the diagnosis of double outlet right ventricle and even a detransposition of right axis. So right axis RVH is a common combination in tetralogy physiologies, but the degree of axis deviation helps you. If the extreme right axis deviation 150 plus, then it's a DORB or a DTG situation. If you have a combination of right axis with LVH, then double outlet right ventricle with a restrictive ventricular septal is a possibility. Normally, double outlet right ventricle will have big, large, non-restrictive ventricular septal defect. But when you have a restrictive VSD, the left ventricle is under pressure load, and therefore you have left ventricular hypertrophy. So right axis deviation with LVH gives you double outlet with restrictive VSD. Right axis RVH, tetralogy physiology, but an extreme RVH within tetralogy physiology can give you double outlet right ventricle. And remember, left axis with LVH, tricuspid atresia, left axis with RVH gives you AV canal. So these 4 diagnoses can be made by looking at this combination. Now, if you have an axis which is neither left nor right, but slightly leftish, instead of being plus 60, plus 30, it is between 0 and, it is closer to plus 90. That is neither normal nor right nor leftish. So slightly leftish means that you could be dealing with pulmonary atresia with intact ventricular. So a slightly leftish axis means you could be dealing with pulmonary atresia with intact ventricular septum. Now, this is something which we often talk about, that you have a right and left axis with equiphasic complexes, absence of transition across the precordium. Now, why do you get a transition? You will get a transition when there is both left and right ventricle present. But if the septum is absent or only one ventricle is there, then you will have absence of transition, and the axis could be right or left. All kinds of things can happen. But once you have an absence of transition, it is likely to be a single ventricle situation. And these are the different types of ventricles, single ventricles. You can have 2 valves which is opening into one ventricle. You can have one valve atretic and the other valve, common valve, opening into the ventricle, or you can have only one valve, single valve, opening into the single ventricle. But you have a single ventricle physiology also. And what is single ventricle physiology? It could either be a single LV or a single RV. But tricuspid atresia also behaves like a single ventricle situation. A hypoplastic left heart or a hypoplastic right heart also behaves like a single ventricle. So within single ventricle physiology, you have these 5 situations: double inlet LVRV, hypoplastic LVRV, and tricuspid atresia. The single ventricle will most of the times have transposition. It is only in about 5 to 10% cases where it will not be transposition. And within transposition, you will have either an infundibulum which is normally placed or an infundibulum which is inverted or gone to the other side. And this is the anatomy of double inlet. You can have a non-inverted situation. This is a non-inverted, outflow tract, and there is no pulmonary stenosis. There is a non-inverted situation where you have pulmonary stenosis, and you can have an inverted situation with pulmonary stenosis and inverted situation without pulmonary. So non-inverted and inverted, PS or no PS. So these are the 4 combinations that you can have, and you can have different types of ECGs on a double inlet left single ventricle, but the axis deviation helps you here. So if you have a non-inverted double inlet, then the axis would be, you have a counterclockwise loop or a left axis deviation. Lead 1, lead 3 shows you a left axis deviation. So a left axis deviation gives you a non-inverted double inlet. On the other hand, if it is an inverted outlet, that means here you have an angiogram of inverted outlet chamber. A non-inverted outlet chamber would be this side, but here it is an inverted outlet chamber gone to the left. And when you have inverted outlet chamber, it is a clockwise loop or an axis which is rightward. Here you have 1, 2, 3, axis is rightward. So the axis will help you in deciding whether the chamber of the outlet is inverted or non-inverted. So the axis, I was trying to emphasize, tells you a lot of things. In the setting of a single ventricle, it can tell you whether the outlet chamber is inverted or non-inverted. If it is non-inverted, the axis is leftward. If it is inverted, the axis is rightward. Single ventricle, if you ask, diagram-wise, it can give you a concordant pattern. It's a negative or a positive. There is no transition. This is what we talked about. No transition. And the other thing which we often talk about is that you have a discordance. There is a discordance between the ventricular hypertrophy and the frontal axis. In RVH, you expect a left axis deviation. But if you have an RVH with left axis deviation, this is a mismatch. Similarly, if you have left ventricular hypertrophy with a right axis deviation, this is also a mismatch. So there is a precaudal frontal axis mismatch. And this is also pointed towards a single ventricle. Early transitions, everybody knows that you have a Q wave, the S wave suddenly appearing from V1 to V2. This is early transition. And this early transition simply means that you have a large, deficient ventricular septum there and the large VSTs over there. So a sudden transition from lead 1 suggests a large ventricular septum. Then the presence of an S wave here suggests a right ventricular hypertrophy. If the P is generally a tall and peaked, it is not tall, it is small and it is peaked. Why? Because the left atrial portion is small. The contribution of the pulmonary, the P wave is made by the right as well as the left. And since the left atrium is underfilled, it does not contribute so much to the production of P wave. And the P wave is slightly peaked and the second part is small. So you have that kind. If you have a pink tetralogy, then you will have some Q wave here and some dominant R also over here. So these are the variations in the ECG which you can get in tetralogy. A slightly smaller than normal P, some prolongation of PR, presence of a Q wave and some dominant R speaks of a pink tetralogy. Otherwise, the classical feature is that from V1 to V2 you will have an S wave transition, early transition, and this is quite classical for tetralogy of Fallot. Then you have ventricular discordance. The second thing is, and when we talk of ventricular discordance, you have to look at the Q waves which are present in V1. Here you have a Q wave which is present in V1, and here you have an absence of Q in V6. So these are the two features which are features of ventricular inversion. In addition, what you will get is an upright T in AVR inverted T indeed one, and AVL. So these are the features of ventricular inversion. That means the right atrium is, the right ventricle is on the left and the left is on to the right. The connections are generally RA to LV and LA to right ventricle. So ventricular inversion you can get on the ECG, absence of Q here on the left side, presence of Q on the right side, T wave upright AVR, inverted in one AVL. Left L transposition is the commonest cause of ventricular inversion, but even normally related great vessels can have isolated ventricular inversion, but basically just talk of L transposition of great arteries. How do you differentiate between the ECG of tetralogy and triology? In tetralogy of fallow, the P wave will not be prominent. We said the P wave will be small, and it is small because the left part of the P wave is not prominent because of the underfilled left atrium. There will be no Q wave here, and there will be no ST segment depression. So tetralogy will have smaller P, no Q, and there will not be any ST segment depression. And of course, there will be an early transition from V1 to V2. On the other hand, in triology, you have right axis deviation, you have ST segment depressions, late transitions, and right atrial overload as shown here. You will have a tall P, you will have a Q wave, you will have an ST segment depression, and you will have a late transition in V5, V6. Here in tetralogy, the transition was occurring in V2. In triology, the transition is occurring in V5. So the features of triology, ECG features are very classical. Tall P, Q wave, ST segment depression, late transition. In tetralogy, it was no P, tall P, no Q, no ST segment, and early transition. So this is the ECG of here. We are getting to the end of the ECG part, and perhaps the X-rays we've already taken, so we can end with ECG. We have a couple of slides on the ECG left, Mohit. And hello.
Yes, sir.
So 5 more minutes on the ECG.
Yeah. Please.
And then we've already talked about the X-rays and the X-ray, and it is only a revision. But let us complete the ECG part. So ECG we have said. In what about double outlet right ventricle? The ECG in triology and tetralogy we have seen. The ECG of Ebsteins is quite classical. Generally becomes abnormal by 5 years. You may have a tall P, may not have a tall P. You can have a biatrial enlargement also. You can have a tall P. Why? Because of the right atrial overload. And because the right atrium is so dilated, it may not generate that kind of pressure. So the P may not be tall. But generally, when you talk of P in Ebsteins, we talk of a tall P, although you don't see it here in the ECG. Then you have a right bundle branch block. And then the input is important that the R dash in right bundle branch block of Ebsteins is generally less than 7 millimeters. And the QRS is a very peculiar character. It appears to be splintered, and it appears to have another QRS superimposed on the first QRS. So it is generally splintered or a double QRS here. It is an RBB, but the R dash is less in height, less than 7. And then you also have, in about 30% of cases, which I have not mentioned here, you have a type B WPW. And even you can have a WPW situation with a normal PR in patients with Ebsteins. So Ebsteins in about 30% will have some WPW or even have excitation without a short PR as a normal PR situation in about 10% cases. So WPW is quite common with there. So these are the features of Ebsteins anomaly that you should know. And lastly, let us just discuss the ECG in double outlet right ventricle, because that is a very interesting situation. Now let's look at the first column here. The VSD most of the times is subaortic, sitting below the aorta. In about 8% cases, it is below the pulmonary, and it could be a doubly committed or it could be uncommitted. So these are the 4 types of double outlet right ventricle, and then it could be with side to side. It could be D malpositions, could be in L malpositions. There are no transpositions here. There are only malpositions. Both the great vessels lie side by side. But when you have a subpulmonary stenosis, there is generally no pulmonic stenosis, and this behaves like an increased flow situation and often presents as an L transposition, the Taussig Bing variety said to be a type of transposition. So the one which has a VSD sitting below the aorta behaves quite like tetralogy of Fallot. The one which is sitting below the pulmonary valve without any pulmonary stenosis behaves quite like a large ventricular septal defect, even a transposition situation, and you have this as a Taussig Bing anomaly. So side by side, and then you can have malpositions of the D type where the aorta is slightly to the right, and L type, but this is the most common situation. And this is which is going to determine the type of ECG which you're going to see in the RV. So the predictive value of ECG in DRV is low, but it varies with the clinical types we have just enumerated. RV hypertrophy is universal. You will always get right ventricular hypertrophy in double outlet right ventricle, but you may get an additional left ventricular hypertrophy also in a situation where there is increased pulmonary blood flow or the ventricular septal defect is restrictive. Now, in the tetralogy type double outlet, which has a subaortic ventricular septal defect with pulmonary stenosis, with right ventricular hypertrophy, you have right axis division. In a large VSD-PS, the axis here, we have already talked, will be greater than what you expect in a simple tetralogy. So in a double outlet right ventricle of tetralogy type, large subaortic VSD with severe pulmonic stenosis, the axis would be in excess of 150. If the VSD is small, if the ventricular septal is small, we do not expect any volume load, but we expect a pressure overloading of the left ventricle, and you will have left ventricular hypertrophy. So as I said, always you will have RV, but in addition, you can have LV also, especially if the ventricular septal defect is restrictive, where you will have pressure overload of the left ventricle. Now, if DORB of the VSD type, what does it mean? DORB of the VSD type, which we have just said, you have a subaortic ventricular septal defect, but there is no pulmonary stenosis. So once there is no pulmonary stenosis, you have increased pulmonary blood flow. And when you have increased pulmonary blood flow, the left ventricle becomes volume loaded. And how does it manifest in the ECG? Tall R waves with deep Q waves in the lateral leads. Always remember that increased pulmonary blood flow leading to left ventricular volume load leads to small or larger, slightly larger Q waves in V5, V6. So even in tetralogy physiology, if it is a pink type of tetralogy physiology, you can get a Q waves in V5, V6. So similarly, if it is a VSD type double outlet where there is a VSD subaortic region, but there is no PS, volume load of the left ventricle because of the increased pulmonary blood flow with left axis deviation. Here, the axis was rightward. So if you have a double outlet with left axis, it is without pulmonary stenosis. If a double outlet with right axis, it is tetralogy, that means with pulmonary stenosis. Now, if your VSD is sitting below the subvalve, it's a pulmonary valve. That means it is a TTGA type of DORB, which we call the Taussig Bing variety. Once again, the pulmonary blood flow would be large, but here the axis would be rightwards, because in transposition physiology, the axis is always rightwards. So how do you differentiate the three? If you have tetralogy type, axis would be rightwards. If you have a VSD type, the axis would be left. But increased pulmonary blood flow will mean tall R waves here. On the other hand, if you have a TGA type of double outlet, the Taussig Bing variety, you will have left ventricular volume load, but the axis would be rightward, because TTGA always has a right axis. If on the other hand, you have a VSD which is smaller than the large one, there will be pressure overload of the left ventricle, and you will also expect a tall R wave and some degree of left axis. So a wide variation can be had in the ECG, and that is why we say the predictive value of ECG is low. But these are some things which can be helpful to you. Eisenmenger physiology ECG behaves in very well like that in tetralogy. That is that if you have RVH with RAD, these are the situations. If you have RAD with LVH, single ventricle situation. LAD LVH, once again, tricuspid atresia, single ventricle going into Eisenmenger. So wherever you have a combination of LAD LVH in a blue baby or a blue adolescent, always think of tricuspid atresia because you expect RVH and RAD. If you have RVH RAD, it is Eisenmenger, it is tetralogy physiology. If you have an extreme right axis, then that extreme right axis could be in the setting of a double outlet right ventricle. If you have a northwest axis, could be having an AV canal type of defect or a large inlet VSD. So I think that is all about the ECG and the X-rays. I think is we have already discussed in the earlier lectures, but if you want, then subsequent, whenever the time comes, we can take one sitting for X-rays in congenital heart disease, because that is also quite interesting. And the flow. But yes, before I sort of finish, I promise that, we will take this. Okay. So just 2 minutes on this. So as I said, often you are forced whether it is PS or PH, and you have to depend upon the X-ray. So whenever you are given the X-ray, look at the pulmonary bay, and you will find that the pulmonary bay is empty, or you find that the pulmonary bay is full. Now, this obviously is a PS situation. This cannot be a PH situation. But this can be a PS situation, and it could be a PS situation. Could be pulmonic stenosis also, because here also in pulmonic stenosis, you can get a prominent. So when you have an absent pulmonary at an empty bay here, you are definite about pulmonary stenosis of the subvalvular variety. If you have a full pulmonary bay, a prominent main pulmonary artery, it could be valvular PS, or it could be a pulmonary arterial hypertension. So the next step is to look at the right coronary artery. Now, if the right coronary artery is also, the right pulmonary artery, and if that is also prominent, this is pulmonary arterial hypertension. If it is not there, it is pulmonary stenosis. So very simple. Absent main pulmonary artery, subvalvular pulmonic stenosis. Present pulmonary artery in association with the right pulmonary artery also, pulmonary arterial hypertension. Main pulmonary artery is swollen, no right pulmonary artery, PS situation, like in this example. Main pulmonary artery is prominent, but the right is not there. Main pulmonary artery is prominent, but the right pulmonary artery is also prominent. So this is PS, and this is pulmonary arterial hypertension. Okay, so now I think we should stop here because already, past 10 minutes past 7. And X-rays we've already taken once, but if you want, then specific to congenital cyanotic heart disease, we can take up the X-rays and even the echo part in a subsequent lecture. So with that,
thank you. Thank you so much, sir, for a very exhaustive lecture and giving us a very practical approach to all our fellows and residents. So if we have any comments and questions and clarifications from our chairs, our panelists, Dr. Sumod, Dr. Arima, and Dr. Girish, we would be happy to take them any comments or anything that they would like to ask.
So generally, the Dr. Tendon's classification is a very simple way to follow. One difference I noticed that, sir, when the classification that, sir, you have shown, like Epstein is considered as like a triology physiology in Dr. Tendon's classification, but sir, you have put in miscellaneous group.
The miscellaneous group, yes.
So any particular
triology, basically, to my mind, is when you have, I mean, I don't disagree with what Dr. Tandon. Of course, he's the master of it all. Basically, the physiology is the same. You have a functional pulmonic stenosis there, and you have a valvular pulmonic stenosis in the other. So in triology, it is a functional. In triology, it is a valvular PS, and in Ebsteins, it is a functional PS. So yes, one can classify it, but to my mind, I think triology should mean a valvular PS with reversal through, and Ebsteins should be classified as miscellaneous. But I don't think it is going to make much of a difference because nobody asks you a classification in the examination. It is for your own remembrance that you need to classify it and remember it as a tetralogy physiology or transposition oblique admixture lesions or triology or Eisenmenger and miscellaneous. But yes, when you can place it in the triology group, Ebsteins Anomaly.
Now, sir, when we say, admixture, true admixtures in general are relatively rare, and making a clinical diagnosis of admixture may be little challenging.
That is why I said.
Yeah. So rather than saying that it will
because
be better to say
admixture lesions are generally, they present to you in the early infancy and early child.
No, instead of that, we can say TGA physiology. We are not saying TGA transposition is there, but we are saying TGA physiology in the sense that
that's what I said.
That should be
TGA physiology. This is what it has been interchangeably used. A lot of people will consider transposition physiology and the admixture lesions as transposition physiology, and say that transposition physiology perhaps is not a correct term because many of these physiologies are not actually transpositions. So, and transpositions may not always present with increased pulmonary blood flow. Admixture lesions will always have an increased left to right shunt. In general, it is a left to right shunt, despite the fact that the mixing is occurring, but the shunt is predominantly left to right. So in transpositions, you may not always have a large shunt. So these are things which you can discuss, but yes, people have used admixture lesions and transposition interchangeably with some caveats.
Sir, in explaining pink TOF, it is better to say that they all have severe PS. Maybe some of them having some milder form of severe. No, it's mildly severe kind of thing. Rather than saying it is a mild PS, it is better to say it's all has severe PS.
Pavlov has said that you have a large VSD with mild PS, and because the PS is so mild, the shunt is the blood flow is not so reduced, and since the blood flow is not so reduced, in fact, it is increased because of the VSD. The cyanosis does. So Pavlov has gone on to say that you can have a mild PS in the setting of a large VSD.
So mild PS means.
So you are trying to say that you have a very, very poorly understood situation.
No.
Pink tetralogy is a very poorly understood situation. We are saying that pink tetralogy is tetralogy means severe PS. That's what you're trying to say.
No, otherwise what will happen is that when we say it is mild PS, large VST makes RV pressure equal to LV pressure, and mild PS means the PA pressure is going to be PAH, which cannot be a situation in a TOF. So, so saying a mild PS make a PS PAH situation, which will be very difficult to
no, but if you have a subvalvular PS in the setting of a VSD, and subvalvular PS is not severe, you expect the PA pressure to be high.
No, we need to take the RVT obstruction in together, in sense that in ventricular plus valvular PS. Any of them could be mild or it could be mild valvular PS, but in effective, the RVT obstruction.
So what do we call a pink tetralogy? How do you define pink tetralogy? When we go ahead and say pink tetralogy, what do we say? The patient has?
The RVT obstruction is severe, but it may not be that severe enough to produce, the deep cyanosis. That which only we can say. We can, because otherwise.
So your objection is that you should not call it a mild PS.
RVT obstruction is severe. Yeah, RVT obstruction has to be severe. Yeah, we were also discussing about the ECG, D or V, but generally we say counterclockwise loop. Suddenly we think that
that is a question. That is the answer that one has been giving since time immemorial. How do you differentiate between an ECG of a double outlet right ventricle and a tetralogy physiology? And we used to say that you have a counterclockwise loop in double outlet right ventricle, and you have a clockwise loop in tetralogy. You have no R waves in V5, V6 in tetralogy, but you can have R waves in double outlet, and then P wave prominence could be there in double outlet and not in. So this is the classical, 3 point answer that we had to give when we were talking about differentiation. But yes, agreed. Counterclockwise and clockwise, I did not mention in the differentiation between because I did not take up the differentiation between top and, but you rightly pointed out the difference is that you have a counterclockwise in double outlet and you have a clockwise in inlet. But yes, I can agree to that, because see, pink tetralogy is such a poorly understood condition. But yes, I quoted Parlov. Yes, Parlov says mild PS, but your objection is sustainable, that you should not call it tetralogy, even if it's pink, as to having mild PS. It should be severe PS, but not severe enough to cause that kind of cyanosis. Agreed?
Sir, many of the examiners are, they want to know about the level of pulmonary blood flow, increased QP or decreased QP in an adult who is a cyanotic congenital heart disease. Do we actually see any adult congenital heart disease with increased QP, sir?
Adult congenital cyanotic.
Yeah, cyanotic. Like maybe a 20-25 years old cyanotic congenital heart disease we are looking at. But
So you have a bidirectional shunt, then it's often you can miss the degree of cyanosis, and if it is around.
We can have TAPVC. TAPVC can have adult patient especially may not have severe PH also. TAPVC can have, only thing because Sir has told, because the pulmonary flow is so good in them, the cyanosis may not be so much evident also in many of them.
So TAPVC can have good pulmonary blood flow. You can have arterial saturation, which is, the pulmonary saturation can be high as well as low. Aortic saturation can be high as well as low, depending upon the streaming. If you have drainage into the superior vena cava, then the unsaturated blood comes to the right ventricle and it is supplied through the duct. On the other hand, if it is below the diaphragm into the IVC, the more saturated blood goes via the ASD into the left side, and the aortic saturations can be higher. So preferential streaming, which is advantageous, can lead to less saturation and more saturation depending upon where the drainage is. So as was pointed out by Dr. Sumod, that cyanosis can vary in TAPVC depending upon pH as well as depending upon the preferential streaming, whether it is advantages or non-advantages.
But one of the causes.
But as you said, that can you have a left to right shunt and still be less cyano? Could be still be cyano. That is what admixture lesions are all about. But then in adults, it is difficult to get it.
But sir, one of the causes enumerated for the causes of Eisenmenger by Paul Wood was TAPVC. So we all know that Eisenmengerization occur within first 2 years of life. But what is the usual course of Eisenmengerization in TAPVC, sir? At what time?
The timing I would not be able to give you.
That I think the Eisenmenger mostly it is with post-acute lesion, that kind of a fast thing, because in in TAPVC like AST, because it is a shunt that is occurring at the pre-tricuspid level, there is probably some regression of the pulmonary. There is some time for the pulmonary vasculature to regress and all. There are many patients. We recently had a 40-year-old coronary sinus TAPVC with PA pressure maybe 28 or something. So it is very common to have TAPVC with no Eisenmenger.
Yeah, I think that you've given the right answer in the sense that, as was pointed out by Dr. Girish, Eisenmenger in PD and VSD situations, sets in by year 1. But in ASD, it sets in about 10% of the time that will set up in the first year. So TAPVC will behave like an ASD, and there the Eisenmenger can be delayed. And often you may not get any Eisenmenger even, and still you have increased left to right shunt. So TAPVC can be a delayed Eisenmenger, but at exact point, as the average year mentioned for ASD is about 35. So what would that age be in terms of TAPVC Eisenmenger? That perhaps I will not be able to give you a specific answer. But yes, it tends to behave more like an ASD Eisenmenger versus that with ASD, with VSD PDA.
Many,
But
some of the
I would
residents-
not be able to give you the answer at what age you
Yes,
are likely to get Eisenmenger.
sir, one more question which has come from the residents is, can you explain something about the loop in ECG?
Actually, loop is basically dependent upon the vector cardiography which you used to do. And I really would say that is just remember that D and the loop, the counterclockwise and the clockwise loop. Just remember, counterclockwise basically is one AVL Q, means left ventricle forces are increased, and clockwise means Q in 2-3 AVL means the right ventricular forces are increased. And I think more dependent upon the vector loop, which you don't get to see these days, and we used to see a long time back. Yeah, you make your comments, Dr. M, if you want to give another answer to that about the loop. But this question which students often ask, sir, what is loop? You tell us it is counterclockwise. So what I tell them that when you look at the vector cardiogram, which they may not have seen, but we have, then on the screen you see the loop moving like this. So if it is moving like this, it is clockwise. If the loop is moving like this, it is a counterclockwise. So it moves in the counterclockwise loop in a left ventricle situation, moves in a clockwise situation in a RB situation. So basically, I think it is manifesting on the ECG as Q waves in 2-3 AVF and 1 AVL, but it refers to the vector group and at how it moves. How it moves. It moves clockwise or a counterclockwise. But you can go on to the net and see how the vector cardiogram behaves, how the frontal, the QRS vector. You have vectors for P, T, and QRS. So how the QRS vector moves on the vector cardiogram, I think that they will be able to.
Because most of them, they get confused with clockwise rotation and counterclockwise.
No, rotation is different.
Yeah, that is what they get confused.
That is rotation is different. That is different. That you have a rightward shift or a leftward shift and a rotation of the heart. Rotation and loop is different. Loop is basically vector.
Okay, thank you, sir. Thank you so much for your talk today. And we've got a different perspective and different approach of cyanotic congenital heart disease. We have been listening to all the lectures across the year, and thank you so much for taking 2 wonderful sessions and guiding us, steering us through this difficult topic and trying to simplify it for the residents.
You know, instead of simplifying it, I think I made it more complex. But I tried to be more comprehensive.
Actually, once residents read it, and they will be able to correlate with your session much well, because your session is coming after years and decades of knowledge which has been knitted down into an hour's lecture. So definitely
But I think I need to go back and read more of pink tetralogy and TAPVC.
Learning, sir, actually the biggest thing is that the challenge is that exam, I'm again quoting your slide only, that the students are facing different kind of examiners, and once a person is going to take an exam, he would always like to listen the answer that he likes or what he knows, he wants to know. And that is the biggest challenge that students face. In fact, that is the major challenge. And very few teachers we have who are able to accept and energize the students and bring out the answers from them. That is an unfortunate part. Probably many of the newer generation teachers and many of the yester teachers are trying to modify their teaching style. So probably this is going to evolve as the time passes by. But this whole...
We are also going to starting off with a CSI teaching session twice a month.
Very nice.
On the first and second, on the second and fourth Sunday of every month. I think Dr. Guha is in charge of that program.
Nice.
I think we are going to have it.
That will be a great idea for our residents, and we'll be very happy to promote.
I think they will take some feedback from you, because Rakesh Yadav said that you have such a wonderful program, PG program running every Thursday. So they will take some help from you also. Take your guidance regarding the planning and regarding the sort of syllabus that you want to cover and what are the subjects and how. So I think they will get in touch with you. Dr. Goa will get in touch with
Surely, sir. Surely, that will be a pleasure. So, I thank you, sir, again, once again, and we'll keep on disturbing you, bothering you, bugging you in near future also. I thank Dr. Arima, Dr. Sumod, and Dr. Girish, my colleagues. Thank you, Intas, for providing us this platform. Next week, we are going to continue with congenital heart disease, and we are going to talk about probably about the epidemiologies and the natural history, which is still a left topic. And we'll soon be starting with the clinical case sessions also, as many of you have demanded. So if you have any particular sessions or topics which need to be covered, or any particular lecture you would like to hear, please feel free to write to us on our email pgtrackcsidb@gmail.com. We would be happy to hear your feedback, because this is your own large academic family, and we would be happy to present those, request those respected teachers to come and present their sessions. So meet you next Thursday, same time at 6 p.m. Have a
Thank you.
wonderful and a safe weekend. Thank you so much.
Thank you and good
Thank you,
night.
sir. Thank you. Thank you, sir.